this tooth, because it is enclosed, cannot erupt to a normal occlusal table, it remains submerged. So this is a submerged deciduous sacillary tooth. Now, what do we do as an orthodontist? You have three choices. Either extract it in the beginning of the treatment and close the space, or maintain this, complete your orthodontic treatment around it, or extract it in the beginning, middle, or end during the treatment as needed, maintain the space and rehabilitate it using the implant or bridge or whatever you've seen suitable with respect to your patient. Now, how do we decide which one is the best option? First thing is, you have to always consider the occlusion between the posterior teeth. Now, if I am going to extract this and protract everything, there is a chance whether this will have any opposing contact or not. So if the patient has 8 extracted previously or congenitally missing, and you remove this one and mesialize everything, maybe the lower 7 will have no opposing tooth. That means in that patient, protraction and closing the space may not be a good idea. You will close the space, then 7 will superride it, then you will extract the 7. Isn't it? So these decisions you have to make carefully. Maybe the patient, no doctor, I don't want FPD, close the space. Can you close the space? Yes, I can close the space. Close the space. And both have decided and not thought whether it is good idea to close the space or not. Yes, you can close the space, but whether it is a good idea or not, that also has to be taken in consideration. Understood? So, first we will see whether it is a good idea to extract and close or not. If it's not a good idea, then you will ask the patient, you will have to put a bridge or an implant later. We cannot close the space, otherwise you will have no opposing contact on the last teeth lower. Okay, now you have two options. Either you can extract at this point, then you will have freedom to move all the teeth as you want. Because this is an ankylosed teeth, definitely you cannot bring your molars forward for good finishing, or you cannot disguise the anterior segment too much for good finishing. That means you will have limitation for finishing. Because remember, 2.5 is a narrower tooth compared to a deciduous 6.5. Yes? That means there would be a tooth size discrepancy. That means your finishing will be compromised. So if the patient says, yes, I am going to rehabilitate this, or I am ready for FPD or an implant later on, you can do some grinding of the tooth to reduce it to the size of a premolar and do your finishing. But if the patient says, no, I'm not decided now, or maybe I want to maintain this as long as possible, then you cannot do this trimming and all those things. That means you have to tell, okay, in that case, your finishing may be slightly compromised, it's not a big deal, but you will not get a perfect occlusion on this side. So these decisions has to be discussed. Clinical relevance is clear? Nicholas? So we have a submerged tooth, and this is after finishing the treatment. If you see, here the canine and premolars are not settled well. Ideally, I should get canine slightly more distally to occlude with the lower canine nicely, and the settling has to be good. But because your upper deciduous molar is wider and thicker, you have reduced space compared to a premolar, so you cannot displace it further. This is the consequence which we accept. Now, if the patient would have told me, I will replace this tooth after I finish the orthodontic treatment, then I would have reduced the mesial and distal aspect of the tooth. I know it is going to, you will have to reduce 2 mm from mesial aspect, but anyways, after the treatment, we are going to extract the tooth. So we could do that and make the finishing better. But the patient chose to keep this tooth as it is. Is this point clear? Again, another set of intraoral examination is soft tissue frenal attachment. Now we all know midline diastema, scapula, thick frenum, all these things. We will not go into details. About examination, we will do it when we are here on chair side. Alright. So there is a thick frenal attachment and there is a very thick frenal attachment, and there can be a thin frenum but it is penetrating deep. How do you check whether this frenal attachment is the cause of midline diastema, or do you require frenectomy or not? So first thing, if you don't have a midline diastema, even if your frenum is thick or if your frenum is penetrating, it doesn't matter. Frenum attachment is a problem only when it is causing a problem, isn't it? So if you have a midline diastema and then you check that frenum is thick or it is penetrating, you have a classification, right? Penetrating, capillary penetrating, all those things. So what do you check? You do a test, you pull the lip away, and then you check whether there is a blanching. Where do you see the blanching? Frenum area? Papilla? If you do it for every patient, you will find blanching on the papilla. You have to actually see on the palatal side. That is when the fibers of the frenum is transversing on the palatal aspect and attaching onto the incisor palatal papilla. So this is the capillary penetrating. So when you do frenectomy, you will have to sever these fibers also to prevent any relapse. Alright? Another sort of examination is periodontal examination. For that you will have to check your OPG and also have to check clinically. So clinically you have to check the general oral hygiene. You have to check whether there is any mobility in the tooth, whether the periodontal support is good or not, whether the bone is good or not in a OPG. If you miss out on this or you get hyper ambitious, that means you say it's okay and I will start my treatment, you will end up with this situation. So grade 2 mobility. Alright, so you make sure that any patient who has any compromised periodontium, make sure the periodontium is stabilized, there is no active inflammation or active infection before you start your orthodontic treatment. Otherwise, orthodontic process is also an inflammatory process. Yes? When you apply forces, there is local inflammation, then there is bone resorption, and that is how your tooth will start moving within the bone. But the good thing is, this is inflammation without infection. So it is physiological. Whereas this inflammation is with infection, so it is pathological. So if you are starting an orthodontic treatment and there is an infection around already, this inflammation of your orthodontic treatment gets superimposed by infection of your periodontium and it becomes pathological and you will have more periodontal breakdown comparatively. So make sure there is no active infection when you start an orthodontic. You can defer the treatment for 3 months, 6 months until oral hygiene is established. See, probing depth and infection is a different thing. You may have deep pockets, but now the periodontium is stabilized. So the idea for me is, as an orthodontist specialist with experience, I will take up a case even if there is 25% of bone loss. I will try to do things to manage it. But at your level, if it is, you see a frank bone loss which is 10%, 20%, better refer to specialist. You will not, don't take up periodontal cases in your practice. Simple as that. If it's a healthy periodontium at your level, I'm talking about your level. Okay? As a class, your level is a beginner. Or if I also consider some experienced practitioner, I would say beginner to intermediate. Beginner to intermediate shouldn't take up periodontally compromised cases, even if it is little periodontally compromised. Periodontal, not gingival. Gingival information, it is okay. But if you see a bone loss, generalized enormity, you don't take up those cases. Refer them to specialists. Just a little. Single tooth you can, yes. Generalized. I use the word generalized. Single tooth, you have to be extra careful. If that bone loss around the tooth is around 25% slight recession, okay, you can work around it. But if it's more than half bone is reduced, you see almost the root is exposed, you don't take up that case. You will have to learn to leave the case. I know in your practice, private practice, this competition is very high. Sometimes you are not the bosses. Your bosses shut down the cases on you. You may have this question, doctor, I told the patient I cannot treat you, but my boss wants me to treat, and this is your personal problem. I cannot deal with it. I can suggest what is good for you, what is bad for you. How to navigate this problem, you will have to convince your bosses. Sometimes I've been teaching for quite some time, and I have students of all the acumen and all the temperament. Some people, they just want to try anything and everything which comes to you, and it's not bad. It is their temperament, they're not doing something wrong. But as a guide, my duty is to tell you this is not for you. Even that, if you want to try, you will ask me 10 ways for me to say yes, and I will find out 10 ways to say no. And after that, you will again ask me, but doctor, the patient says, I want only you. There are so many things people want us to do, but if we don't want to do it, we don't do it, isn't it? Similarly, if the patient is forcing down to do it, the patient, I want to do with you only, doctor, my boss is telling, it is your choice whether you want to do it or not, you want to take that path or not. Maybe you will be successful with that patient, but as in my experience, I would always say this is not a good case for you. So when we have some case discussion during next 1 year, 2 year, and you post some case, be frank and post any case which you like you want to take. But if I think it is not a good case for you, I will frankly tell this is not a good case for you, and then we will discuss that case. That how can we treat it? And after that I will tell, but you don't take up that case. There will be some cases I will tell you, don't take up at all, you don't take up. Some cases I will say, it's not a good case, but if you want to take up, you can take up. Then you have to decide whether you're capable enough or not. Understood? Because everybody will learn at a different speed. If you're confident and you think you can take up, you take up. If you think it's too stressful, too difficult, or you don't know how, then you transfer. Some cases I will say outright transfer. Clear? So for some months we have to stop treatment for such patients until the periodontium stabilizes and then continue the treatment. So this is the case after almost in finishing. Now when you have such cases, you cannot spend a lot of time in finishing, so you have to achieve the important targets and finish the treatment. Because cost to benefit is too high. If we spend more time in final detailing and all that, we may compromise the periodontium more. So the main problem was proclination. We could achieve the proclination, we could achieve good overjet, good overbite, everything finish the treatment. Don't go into final details. So soft tissue intraoral examination is clear. We look at periodontium, we look at gingiva, we look at frenal attachments, we count the number of teeth. All these things is done. Clear? Now we go into hard tissue examination. So soft tissue examination, first thing which we get is, I'm not talking about tongue. Tongue we will talk in tongue first. But for now we are going to skip the tongue, and tongue examination, all these things are overhyped. It is not so relevant, but anyways, we'll discuss it later. For periodontium, you have to check for any recession, any abnormal attachment. That means high frenal attachment can cause recession also sometimes. You have to check OPG, you have to check the bone type and the bone support for individual tooth. There are sometimes some clefts because of local periodontal issues or frenal attachment. That you have to take care before you start orthodontic treatment. If there is high frenal attachment around that tooth which is causing a recession, you may have to do frenectomy in the beginning. Not midline frenum attachment. There is also lateral buccal frenal attachment around canine and around premolar. They can lead to local recession. So you have to take care of all these things. I'm going to go faster because as a general dentist, you will know all these things better than me. Whatever is orthodontically relevant, we will spend more time. So any patient who has gingival hyperplasia, enlargement, all these things, you will have to take care before you start the orthodontic treatment. The key for all periodontal and orthodontic, perio or gingival, or perio or endo problem is, when you are starting out the orthodontic treatment, there should be no active infection available in the mouth. That is the key. Yes? Now, this is very important. This helps us make a clinical decision. So we have covered the external features. Now we are on intraoral features. Gingival biotype. This is clinically relevant. We'll spend more time here. So gingival biotype. What do you mean by gingival biotype? There is a normal gingival biotype which we all have and you have seen and you have not paid attention to it. It's a normal gingival biotype. But sometimes you see some patient where almost all the root prominences are visible and the gingiva looks as if it's a thin sheet of plastic over the bone. Very blanched, very clearly the roots are visible and you feel it's too fragile. Those are thin gingival biotype. Can you see? Inflamed, thick, and all the root prominences are visible. The gingiva is totally blanched out. They are thin gingival biotypes. Then you have thick gingival biotypes. You have patient where the attached gingiva is quite sturdy and well, you can say the color and there is no infection, no inflammation, and you see the thickness of gingiva is quite good. These are thick gingival biotype. Normal or thick gingival biotype are a good thing for us, whereas the thin gingival biotype is not so good for us. Why? Because when you make orthodontic treatment, and if you're doing a non-extraction treatment, the teeth are slightly going to procline. And in a thin gingival biotype, the gingiva is thin, the bone support is not so good. If the teeth are going to procline, they are more prone to recession. So if you have a thin gingival biotype, pay attention and don't make notes. If you make notes, you'll make mistake. If you have a patient, if you have two patients, exactly same features, exactly same crowding, exactly same facial type, two identical twins. So the treatment plan for them has to be same in terms of a clinical objective. That means you don't want to change the face and all those things. There is moderate crowding. That means we need to relieve the crowding. Only one difference in that. One has a thin gingival biotype, another one is a normal or a thick gingival biotype. Now this is a borderline case. So this is a scenario I am giving you. It is a borderline case. If you do extraction, you will get the same result. If you do non-extraction, you will get the same result. Which patient would you choose extraction and which patient would you choose non-extraction? I'm not asking you the question where extraction is a better option or a non-extraction is a better option. In borderline cases, you'll get the same result with both. But I'm asking you for which patient extraction is a good option and for which patient non-extraction is a good option. Extraction for thin gingival or thick gingival? Okay, you understand? You are able to make this link. So the key is borderline. If your case requires extraction, you have to do extraction. If your case requires non-extraction, you have to do non-extraction. But there are some cases, 20% or 30%, which are borderline. That means you will do extraction, you will get the same result. You will do non-extraction, you will get the same result. These borderline cases, if they are thin gingival biotype, go for the extraction option because you don't want to procline more. If these patients are thick gingival biotype with good periodontal support and other feature can accept non-extraction treatment, then you can attempt non-extraction first because you can allow the teeth to expand slightly and your periodontium will not be compromised. So the key is borderline. All these factors, all the factors which we will discuss, extraction or non-extraction, extraction or non-extraction, they will always hold true only for borderline cases. Because very outright, if your crowding is 14 millimeter, what would you do? Extraction. If you have spacing of 10 millimeter, what would you do? Non-extraction. So outright decisions we are not discussing, we are not questioning, we will not discuss. You will see it and you will know it. But the discussion will be mainly on cases where you will be confused, the borderline cases. There we have to see all these factors. All these factors which we discussed, they will come into play and we have a scenario where you will consider all these factors. Alright? So one of them for intraoral is gingival biotype. Is there any confusion? I want you to understand this clearly. Is there any question on gingival biotype? Now, this is in your notes. We are not going to read line by line and waste our time. By this, the linkage is vertical growth patterns. Vertical growth patient has thin gingival biotype in most of the situation. In most vertical growth pattern, dolichocephalic patient, they have thin gingival biotype. So they are usually more prone to recession for non-recession treatment. Alright? There is an indirect linkage, there is not direct linkage. So if you see here, it is more important to determine the buccolingual thickness of the gingiva to detect whether the patient will be prone for recession or not. So this is first point. And here it is shown that for vertical growth pattern, the alveolus thickness is comparatively lesser than the horizontal growth pattern. So here it says that you will see thinner gingival type and thinner alveolar bone in vertical growth pattern. And here it says that the thinner gingival biotype is more prone to recession. So what inference can be linked from these two? The vertical growth pattern mostly have thin gingival biotype, and thin gingival biotype mostly are prone to more recession. So if you have a borderline case which is a vertical growth pattern and thin gingival biotype, it would be a good idea to consider extraction if it's a borderline case. Clear? Everyone? So now we are going back to a case which I showed you previously. Once you have this, you see this case. What do you think? It's a thin gingival biotype or a thick gingival biotype? Thin gingival biotype. So in this patient, we have decided to do extraction to relieve the crowding. And we have bypassed this tooth because this tooth was showing some recession. That means I don't want to apply any force on this tooth at all until I create enough space for this to move in. But even after that, you see the recession has started to happen. Understood? So when you have a crowded tooth, always don't bond. See, I see a lot of students, they bond all the teeth and put nitrile wire in a crowded case. It's not a very good practice. A good practice is do sequential bonding. Bond the teeth which are almost well aligned, bypass the tooth which doesn't have the space, later on open the space, then bond them, then align them, then bond them, align them. So you may have to do sequential bonding. Maybe first bond all the posteriors, then bypass two incisors, then one of the incisors have enough space, then bond it, then create more space and then bond it. So you have to do sequentially, right? So we will discuss this as we progress in modules. You will understand everything, alright? What is the target of this module? The target of this module is not to understand how to treat a case. The target of this module is for you to understand what a particular feature looks like and whether I can identify this feature or not. This is the only target. Alright, so don't in your brain get confused whether I should do frenectomy now, whether I should do extraction in this case, whether this case I can take up or not take up, whether periodontally compromised patient is a good patient for me or not. At this stage, you don't need to worry about this. All you need to worry is whether I can identify a periodontally compromised patient or not, whether I can identify a thick frenum or not, whether I can identify thin gingival biotype or not. Only this module, this is the target. Also, you don't need to memorize all these things. You don't need to make these linkages and try to mug it up. They will automatically happen. You will keep repeating these things in every case we discuss. Automatically, it will become your second habit. So now coming to cheek and frenal attachment. Now also remember, like you have transition malocclusion. Have you heard this term, transitional malocclusion? Ugly duckling stage. So do you treat that or not? Why? Because it's transitional. As the occlusion is developing, you will have certain malocclusions at that particular age, and later they will self-correct. These are transitional malocclusion. One of the example is midline diastema during 9 to 11 years. Because canines are erupting, it will cause ugly duckling stage. Yes? Similarly, certain frenal attachment, if they are seen at 5 years, 6 years, 7 years, don't go ahead and do frenectomy for them. Because for deciduous tooth or early dentition, it is common to have thick, deep frenal attachment. But as the alveolus develop, the frenul remains there and the alveolar goes down and the new teeth comes in and the frenal attachment is becoming normal. So for a 5-6-year-old, a Blanch test will always be positive. You will always see a diastema. Is it normal to have spacing in deciduous dentition or not desirable? Desirable. It's a desirable feature. So don't think midline diastema and frenum. Go ahead. It is normal for deciduous dentition to have midline diastema, and it is normal for deciduous dentition to have frenal attachment. But if it goes beyond 9, 10, 11 years, and you see large diastema and also you see Blanch test. Blanch test is not seeing blanching on the labial side. Blanch test is not seeing blanching on the labial side. If you pull your frenum, you will definitely have blanching on the labial side. If you pull your frenum and you see blanching on the palatal side, that means the fibers are transversing from labial to palatal side and the Blanch test is positive. That is when you have to cut the frenum, also sever the fibers. Understood? Also sometimes you can have frenal attachment around canine region which can cause recession. So these, although they are not causing diastema, but they are causing mucogingival problems. So you have to cut them out before you start the treatment. So in my lectures to my students previously in Manipal, I used to ask this question very often for every time, that how do you decide whether you should do the frenectomy in the beginning of the orthodontic treatment or at the end of the treatment or during the orthodontic treatment? How do you decide that? How many of you think we should close the diastema first and after that do the frenectomy? Raise your hand. Raise your hand. Anyone who think we should close the diastema first and then do frenectomy? Very good. How many of you think we should do the frenectomy first and after that close the diastema, otherwise the frenum will interfere? How many of you think? Alright. So let's look into the real way we should do it. So the answer is, we should always try to close the diastema first and then do the frenectomy. The reason being, after you do the frenectomy, it's in your notes, don't write down, pay attention. If you do frenectomy first, the healing will cause some scar. This scar is a very strong and sturdy tissue which doesn't change over a period of time. And this scar will prevent the complete closure of diastema. Even if you are managing to close it, the pressure, the scar tissue will be pressured and it can cause relapse. So the best idea is, wherever possible, close the diastema and then cut the frenum. So what will happen? The scar tissue will be formed after closure of diastema. And what is a feature of a scar tissue? Myofibroblast. Myofibroblast is a contractile tissue. So after you close the diastema and a scar is formed, it is going to try to apply contractile forces. It is going to maintain your diastema. Is this point clear? But there can be a situation the frenum is so thick that you are trying to close the diastema and at one point the diastema doesn't close. So in such cases you should close as much as possible. When for 1 or 2 visits you don't see any further closure and the diastema, the frenum is becoming thick and blanched, that means you need to cut the frenum at that point. And immediately after that you can start closure. Because the scar tissue will take 3 to 4 months to form a mature scar tissue. And the remaining space will be 1 or 2 millimeter, which will be closed in 1 or 2 appointments. So the idea is, the way is, wherever you can, close the diastema first and then do the frenectomy. Wherever not possible, close as much as possible for you, do frenectomy and then complete the closure. That is the right way for midline diastema and frenectomy planning. So far clear? When you have capillary penetrating, please, if you are the one doing the frenectomy, don't just snip the frenum with laser and done. You have to scrape out the fibers. So you may use a scalpel to sever the fibrous connection which is going from labial to lingual. Alright? So if you see here, it was a huge diastema with a thick frenal attachment in the center. We could close the space, but at this point the space closure stopped. So at this point we cut the frenal attachment and then further close the space. And there is a scar tissue which is formed. You can see this. So this scar tissue will help to stabilize the diastema. Clear? Yes. After, I prefer to do it just before or just after that. So the question is, once we, let's say it was not a very thick diastema, we close the diastema in first 7 or 8 months of the treatment. Do we do phenectomy immediately after that, or can we do it after orthodontic treatment once we finish everything? The answer is, once the diastema is closed, you can continue your treatment and do the debonding, and after that do the phenectomy. But I personally prefer to do phenectomy 1 or 2 months before debonding. The reason being, sometimes if you have inflammation or thick frenal attachment, once you cut, you realize that there is a black triangle formed here. And if I want to correct that, I will still have braces on my teeth, so I can do some treatment and do complete closure. But if you do it after the treatment, and if you punch out the papilla or there is a papillary recession, you have a black triangle, you are in a position where you cannot do anything further. So I always personally prefer to do my phenectomy or any gingivectomy or any gingival procedure 1 month or 2 months before I take off the braces. So that if there is a mucogingival problem, I may be able to do something to improve that situation. We will discuss that when we are discussing IPR, gingivectomy, black triangles, all these things we will discuss this. Hard tissue examination. So soft tissue examination, any question? Mainly, I have not mentioned here phenectomy or high frenal attachment because this board we are writing the things which is important for us to make decision of extraction versus non-extraction. So in soft tissue, mainly we study 3 things, 2 things mainly. One is gingival biotile, second is periodontal situation, and third is frenum. Everything clear? Now we go into hard tissue examination. Hard tissue examination, as I discussed, it is mainly examination for tooth relationship and tooth. So first thing, we have to count the number of tooth. Second thing, we have to check whether any tooth is impacted or deciduous tooth is retained. Whether in the X-ray you have all complement of teeth or not. If you have all the teeth, then you have to check whether any tooth is compromised by large filling or any RCT. At any point of time, if you require extraction, we will choose whether we can extract this compromised tooth or not. So this is a generalized view of a hard tissue examination, which you all do in all your cases. Other than that, whatever is orthodontically relevant, we will discuss more in detail. Okay? So I'm going to go very fast in this because it is what is overjet, what is overbite, all these things you know already. Overlap of the tooth is overbite. The distance between the upper and lower teeth is overjet. The normal overjet is 2 to 3 millimeters. The normal overbite is 2 to 3 millimeters. I don't have to repeat all these things to waste your time here. You can go through yourself later. So what is a crowded and a spaced dentition? You already know it. What is a normally inclined tooth? What is a proclined tooth? What do you mean by retroclined tooth? You know all these things. What is an overjet? What is an overbite? Let us not waste our time in this. You all know what is an overjet, what is an overbite. What important thing which I want you to note is overjet and overbite is a range. For some patient, 3 millimeter overjet is normal. For some patient, 1 millimeter overjet is normal. It is the function of thickness of the tooth, inclination of the tooth, how your TMJ is, what is the functional mutually protective occlusion, MPA. So These are complex things which you don't need to understand. What you need to understand is, don't get stuck to a thing that only 2 millimeter is the normal overjet. Only 2 millimeter is the normal overbite. It is not always so. 1, 1.5, 2, 2.5, 3. They are all within a normal range. But we will target ideal. So we will try to achieve 2. If everything is balanced and we can achieve 2, very good. If everything is balanced and there is some reason we are able to get 2.5, it is also normal. For some reason, if we are left with 3 millimeter of overjet, we can do some IPR and correct it to 2, it is normal. So far clear? So why did we get this 2 value? Because they took up normal occlusion people, 10 people, they took an average, some had 3, some had 1, some had 2, and the average came out to be 2. But 2 is not a number, it's a range. 1, 2, 3, 2 to 3 is normal. Do you understand this idea? Similarly, overbite, a 2 millimeter overbite is considered to be normal. In terms of percentage, 10 to 20% of overlap or 30% of overlap of teeth is considered normal. If more than half or half overlap, it's considered to be a teeth bite. Class 1 canine, class 2 canine, class 3 canine, everybody clear about that? Molar relationship, everybody clear about that? What is the class 1 molar, class 2 and class 3 molar? In class 1 we have class 2 division 1 and division 2 based on incisor inclination. Class 2 division 1 is procline, class 2 division 2 is retrocline incisors. Class 3 we have skeletal class 3, and in dental we have Angel's class 3, pseudo class 3 or a true skeletal class 3. So far clear? Everyone? If you have one side class 3 and one side class 1, it's a class 3 subdivision. It's a class 2 one side class 1, it's class 2 subdivision. If you have one side class 3, one side class 2, you cannot classify it as per Angel. Angel did not give any classification. Clear? So whenever you report your cases now, your dental diagnosis will be based on Angel's relationship plus your canine relationship. So you may say that Angel's class 1, Angel's class 2 division 1, Angel's class 2 division 2 or Angel's class 3. Along with that, you have to also report your skeletal relationship. So the complete reporting, this is the dental diagnosis only. The complete reporting for a case would be skeletal class 1 or skeletal class 2 or a skeletal class 3 with Angel's class 2 division 1, spacing or crowding or whatever is the main important feature for that case. Is this clear? Coming on to the arch form, we will discuss the arch form in detail. We have model analysis and arch form a separate topic. We will discuss in detail for that. How do we select the arch form, which wire to be used? It is covered in module 2 also and partly in module 1 also. So basically you have to check whether your arch is too narrow or not. This is what you are basically checking. Whether your arch is too narrow or not, whether you require any expansion or not. If your arch is slightly narrow and there is no cross bite, most likely you don't require a parietal expander. If your arch is not too narrow and you don't have a cross bite, then you put an arch wire, your arch dental expansion, arch will align in itself. So don't go on asking that every case do I require expander, because every case some amount of constriction will be there. Yes? Only if it is substantially constructed, there is no number attached to it because different facial types, different arch forms. If you see a substantial V-shaped constriction and there is a cross bite, you may require it. Clear? If you remember in posterior cross bites, we discussed previously that a patient, because they cannot bite on one side, they shift their jaw, so you see unilateral cross bite, but it is actually bilateral cross bite where the patient is conveniently shifting his jaw to one side. So any cross bite posteriorly, if you see unilateral cross bite, in your mind you must first consider that it is a bilateral and the patient is shifting. So check for convenient shift or functional shift. If you rule out this, very rarely you will have unilateral cross bite. Alright? So in your practice, if you see unilateral crossbite, 90% it is going to be a bilateral crossbite with a functional shift. So any posterior crossbite, please consider checking functional shift. Clear? A posterior crossbite can be classified as normal. This is normal, and any deviation from it is a range of crossbite. So you may have, if your buccal teeth, if your upper teeth are going more buccally, you have a buccal non-occlusion. A Brody's bite or a Caesar bite we call it, where your upper arch is completely entrapping the lower arch. Then if you have upper arch slightly constricted, you have edge-to-edge bite of the molar relationship. That means in cuspal relationship. This is also a crossbite, not so severe, but mild crossbite. Then you have a crossbite which is a frank crossbite, where your upper buccal cusp is occluding to the central fossa of the lower. So this is a frank crossbite. And then you have a severe crossbite, your upper arch is completely constricted and entrapped within the lower arch. This is called as lingual non-occlusion, because your upper arch is lingual to the lower arch. So far clear? Midlines. Remember we discussed midlines and we discussed it in detail. I am not going to go again in detail until someone wants me to repeat all this. Is there someone who wants me to cover the midlines again in the same detail, or can I go fast? If there is someone, just raise your hand, I will repeat in detail. Okay, so I am going to go fast. I am just going to touch the important points. First thing, for midlines you require a landmark. Landmark is facial midline. Glabella and philtrum are the primary, tip of the nose and chin are secondary because they can change. Compared to the facial midline, you will identify whether your upper midline is shifted or lower midline is shifted or both are shifted. If they are shifted, whether they are shifted in different direction or same direction. We have studied that 2 to 3 millimeter of midline shift in upper arch can be considered normal. It's not normal, can be considered normal because layman cannot make it out, even dentist cannot make it out easily. And if it's only an aesthetic problem and we can't see it, it is not a problem. But we will always try to achieve to match it. But if everything else is balanced and you have to do a lot of work, the cost to benefit ratio is not justified, then you can leave 1 or 2 millimeter of midline shift if everything else is balanced. In midline shift, we always make a mistake when we are checking the midline shift and we are not considering laterognathy, lateral occlusion, and functional midline shift or dental-alveolar midline shift. You know the difference between all the three? A dental midline shift is dentition moving here and there because there can be one tooth missing, there can be one tooth large on another side, or there can be some tooth discrepancy or some blocked out tooth and the dentition moves. So that is a dental migration. Then laterognathy is when your mandible is growing one side more than the other side, and entire mandible along with the teeth moves, and it's a midline shift. You see it more common in mandible because mandibular midline laterognathy is more common because mandibular jaw has more chances of facial asymmetry as compared to maxilla, which is rare. Functional midline shift or lateral occlusion is because of any premature contact, any blocked out tooth, any high extruded tooth, any high point, for any reason, if your jaw is biting and then because of that prematurity it is being deflected to one side, it is a functional midline shift. It is always seen in mandible because mandible is the only jaw which is moving during function. Is this point clear? If you miss to identify this, you will make a huge mistake in your treatment. So it is very important. Sometimes a functional midline shift is also remain ingrained in habit, and patient even after the prematurity or the interference is removed, patient keeps biting in the deflected position as a habit. So we consider the convenience bite or a habitual bite also as a functional shift. Is this point clear? Now let us see. Curve of Spee is clear. There was a question that if there is a deep curve of Spee, how much space do we need to correct the curve of Spee? because this is a person who has been practicing ortho, so they have this question. Anybody who is not practicing ortho, they will not have this question. But let me answer this. First thing, we will discuss this later. Now to level the curve of P. What do you mean by deep curve of P? A deep curve of P will be when your incisors are slightly more extruded. The lower incisors are slightly more extruded compared to all the other teeth. That means you want to intrude the incisors to make it flat, isn't it? To intrude, you want to put the incisor, that means the wider portion of the incisor is going to come down. That means you need some space for that. When you do that, the incisors will go down. So to level 1 millimeters of speed, listen carefully. As of now, you don't need to understand this as of now, but I am answering somebody's question. So you may very well listen to it. To level 1 millimeter of speed, that means if you want to intrude 1 millimeter incisors, you require actually 2 millimeter of space. You require 2 millimeter of space. 1 millimeter you will create, and 1 millimeter you will automatically get. I will tell you why. Because when you intrude, the teeth doesn't go in like this. Teeth go in and also slightly procline. This is how in our mouth, because we are limited by bone and geometry is like this. When you intrude the teeth, they will also procline. You can't help it. It is very difficult for you to control this proclination. You can reduce it, but absolutely control is slightly difficult. So when you usually intrude, the curve of P is leveled by proclination and intrusion. So you require actually 2 millimeter of space, but you will create 1 millimeter of space, and 1 millimeter you will get by proclination. So in a loose term, we can say it is 1:1. 1 millimeter of space is required to level 1 millimeter of speed, required by you to gain. 1 millimeter will automatically gain by proclination. So far clear? Everyone? We will take a break now, a short break of 5 minutes. Just 5 minutes only for you to relax, stretch out. Have any question you can ask. I know this module is slightly theoretically heavy, but this is very much needed. We will understand all the theory we need in the first 2 modules, so that we know how to clinically apply them in the remaining 3 modules. There is a question about cleft lip and palate. The answer is don't take up. See, cleft lip palate, even specialists don't take up cleft lip palate cases. Cleft lip palate is a super specialty within specialty. That means all orthodontists don't do cleft lip patient cases. They can do it, but then you require special interdisciplinary training with periodontics and surgical team to get treatment of palate cases. So most of us, we don't take it. We refer it to another orthodontic specialist who is trained specifically for cleft lip palate. At your stage, please don't take up. If it's a cleft lip, minor cleft lip, it's okay. But if it involves cleft palate, don't take up any cases because it is interdisciplinary. There is multiple features involved in that. question that there was a case which I showed. There was a retained deciduous tooth which was ankylosed. Do we bond that tooth or not? So there is a question related to curve of speed. First, I will answer the question which was asked regarding the deciduous tooth. So I asked you a question whether I bond a ankylosed tooth or do I not bond the ankylosed tooth. So answer depends on the treatment plan. If very good question. So if you are planning to derive anchorage from, because it's an ankylosed tooth, that means it will never move. That means if you need some solid anchorage, you can use that tooth, then you bond it. But you have to remember that you cannot do normal bonding for it, because if you bond according to your bonding chart, you are imagining that this tooth will move. And because this tooth cannot move, it will pull everything else towards it. So you have to bond this tooth passively. That means after you bond everything else, you will just put a bracket so that the wire is going flat through this tooth. Okay, you will understand this concept what I am talking now after you do bonding. So first thing, you will have to do bonding modification accordingly. Secondly, in most of the cases, if you are not planning to do anything with that tooth and you were leaving that tooth there because the patient chose not to do anything there, then you don't bond that. Clear? Now there was another question is, if you open your slide with respect to curve of speed. Curve of speed. It will be just a few slides earlier than this. Yeah. In curve of speed, there is a note that we try to target the conservative limit of 0 to 1.5 to overcorrect it. So why do we need to overcorrect it? That is the question, right? See the concept of overcorrection. There will be a lot of time we will talk about overcorrections. First thing is, relapse is a rule. Every patient you treat will have relapse. Not maybe, he will have relapse. Now, we can either do a certain thing to reduce the relapse or reduce the chances of relapse or delay the relapse, but relapse will happen up to a certain degree, and actually up to a certain degree of relapse is desirable, because when you finish your orthodontic case, all the teeth are tied together. So at the macro level, you feel you have done a good job, but actually the final settling, the final internalization at micro level, the proprioception happens after you debond, and tooths slightly adjust themselves according to the remaining spaces. So they settle down finally after you debond. So some amount of relapse helps you to sink in your interdigitation, your occlusion, final finishing will happen after that. So that 5-10% of margin of relapse is good. 10 or 20% of relapse will happen over a period of time. So if the patient asks me, doctor, is my treatment after finishing going to change like this? Yes, absolutely. Then, if you don't want to change this, wear the retainer for life now. Simple. Every patient, if they wish that they have this treatment final result, they want to maintain it for lifelong, wear the retainer lifelong. If you are okay with 20 to 30% of relapse, it is because we grow like this. As we grow old, the crowding increases. So if you are okay with little crowding here and there, you can wear retainer for a few years, and after that, taper it down slightly and then stop. Understood? Now coming to her answer, why do we need overcorrection? Because deep bite has more chances of relapse compared to other malocclusion. So we want to slightly overcorrect it, so that even if it relapses slightly, it will come back to normal. As I told you, there is a note written there, 0 to 1.5 to even 2.5 is considered normal. because it is depending on your biting pattern, your jaw, a lot of multiple factors. So for some patient, 2.5 curve of speed may be normal. But as a clinician, when we are treating the case, we don't want to choose the higher limit of error. We want to choose the lower limit of error as a target goal. That's why we will choose to make it flat by ourselves. Maybe we will achieve it, or maybe we will end up 1.5. Is this point clear, everyone? Now coming to the clinical examination, we have seen there is a functional shift, isn't it? So now the functional shift can be in terms of lateral, which we discussed in midnight. Also it can be in anterior-posterior dimension, or it can be in both. So when the shift happens, we discussed in midnight, either the jaw is being shifted left or jaw is being shifted right. We called it as lateral occlusion. But it can also happen in anterior-posterior direction also. And this difference of biting between a centric relation and centric occlusion, we call it as COCR shift. Everyone has heard this term COCR shift? This is called as functional examination. So every one of us, when we bite, we have some degree of COCR difference. 0.5, 1, 1.5 is considered normal. This is the average study that everybody has a certain degree of difference between centric relation versus centric occlusion. Until 0.5 to 1, it is considered normal. If it is more, then it stresses out the TMJ and starts to cause pathological problems. So we have to rule out in our patient that this discrepancy is not too much. Now this discrepancy can be caused of multiple factors. It can be due to premature contact, or it can be because of the natural anatomy of your teeth, bone and TMJ relationship. So if this discrepancy is just 0.1, 0.5, 1 millimeter, it is basically because of the difference in your jaw and teeth relationship, and it is normal. Alright? Now before we discuss this, we will discuss this in detail in jaw functional examination. It will come after this. That time we will discuss in detail. I will explain more about this. Okay? For now, we are studying hard tissue examination intraoral, so we are just getting an overview of it. Alright? Next topic is functional examination. How many of you has attended any of the full mouth rehabilitation or posterior rehabilitation courses so far in your life, or done a full mouth rehabilitation case? Or anybody who has special interest in prosthodontics, or they are doing a lot of prosto cases? None? Then I assume that you may have the similar kind of confusion which I had as a student. That confusion is, what is a CR, what is a CO, what is an RCP, what is an ICP, what is an MIP, which is the correct term to be used, isn't it? Because certain places we see COCR discrepancy, certain places we see MIP, certain places we see RCP, ICP, and we get confused and lost in these terms, and we don't know what is the correct terminology, isn't it? So I'm just going to spend 5 minutes to solve this out. After that, you can get confused how much ever you want. All the things you need to know is whether there is a discrepancy or not. The term can be COCR, the term can be ICP, RCP, it doesn't matter. As an orthodontist, you need to just know whether there is a difference between the full bite versus the centric bite, or there is no difference. So far clear? So let us go and understand these confusing terminologies. What is a centric relation? Don't need to read the notes, I'm just going to tell you. So there is a centric relationship. No need to read the notes. Pay attention to me. What is a centric relationship? In prosthodontics, there was previously there was a definition which we all try to mug up by heart. The posterior superior position of the condyle where the mandible can show only rotational movement, glossary of prosthodontic terminology, GPT definition. And we read that when the condyle is positioned most superior and most posterior in the temporal fossa, and we call that position as centric relation over a period of time, because that time we didn't have CBCT, we didn't have surgical techniques to look into the TMJ, so they assumed. So this will now is wrong. So if you see any GPT or any articles before 1980s, 1990s, you will read this definition. But the later 1990s and later 2000s, this has been scraped off. Now they don't say most posterior superior. What do they say now? Most posterior anterior. So I think 50% of you may remember this as posterior superior. So please remove that concept. Now that we can see into the TMJ through arthroscopy, through CBCT and through surgical procedure, we have come to know that our previous understanding was wrong. When the mandible is in centric relationship, the condyle is not posterior superior, it is posterior anterior. So if you have your glenoid fossa, I am explaining you surgery and prosthodontics, you can just clear your doubts here and then forget. So if you have a glenoid fossa, your jaw is, condyle is not here, it is condyle is here. So this position is centric relation. Is this independent of tooth relationship or is it affected by tooth relationship? Independent. We did not mention anything about tooth. That means this is an independent relationship. Alright? Now, in this position, the mandible can open and close up to a certain degree without any translatory movement. That means mandible has two movements. Once you start opening the mandible first rotates, and after that it further opens, then it comes down also. There is a rotational movement and translatory movement. So far clear? So in centric, you have a range of how much can you open maximum your mandible open? Open maximum? How much can it be? 35-40 millimeters. Out of that, almost 40 to 50% there is only rotating movement. This is when your condyle is in centric relation. If you open further, it will drop down and come forward. So you have initial movement which is rotational and final movement which is translational. Clear? So centric relation, we know the new definition. After centric relation, mandible starts to open. You have to remember this in terms of mandibular opening. So first is mandible is closed. This is the zero position where mandible is closed. Yes? Then mandible is slightly open. Slightly, 2 or 3 millimeter open. Condyle is where? Condyle is started to move, translation or only rotation? Only rotation. That means condyle is at the centric. So as CR, slightly opened mouth. So this position, there is a particular position where all your opening muscles and closing muscles of jaw are in balance with gravity. We call it as postural rest position. Yes, it is very important for us to understand this position because it will be used for us as a clinician in manufacturing the functional appliances, as a clinician for you to make your dentures and full mouth rehabilitation. So if you are understanding this here, it may also help you as a clinician. So there is a position after 2 or 3 millimeter of mouth opening which we call it as postural rest position. Here all the muscles are balanced. If you keep on going further, another 20-25 millimeter, mouth will keep opening. So there is a range of CR. Initial 0 to another 20 millimeter. The jaw is opening and closing in pure rotation movement, and the condyle is at CR. And within this position, there is a special position which is highly repeatable. In your clinics, you can easily get this position, which is called postural rest position. So the condyle is in CR. There is no occlusion in the teeth, and mouth is open 2 or 3 millimeter. And this position, all the muscles are balanced, and it's a postural rest position. Clear? And if you open beyond this, you will have rotation and translation of condyle. So the condyle will not be in CR anymore. So far clear? Now, if we start to close, this is relevance for all. So far clear, anybody? Any confusion? CR is a condyle related position. It guide the mandible to close further, and the mandible will be guided slightly forward and binding in this position. And before this slides forward, there is 0.5 to 1 millimeter movement of condyle. So condyle is not in centric now. This 0.5 or 1 millimeter move forward, guided by the tool. And we call it as ICP, intercostal position, or MIP. So this is guided by tool. So this discrepancy between RCP and ICP, in an ideal world, your centric relation should be same as RCP, should be same as MIP. That means when you close your mouth, everything should bite exactly the same, but it doesn't happen. In nature, it doesn't happen. But when as a clinician, if you have a full mouth denture case, if you have a full mouth rehabilitation case, you will try to replicate where your centric relationship will be a guide, and according to that, you will make your occlusion. So you will match centric relation with the centric. So far clear, everyone? I will give you 5 minutes to relax. Also, if you want to read out and clarify your doubts in your minds with respect to this definition, you can do it. For us, I just spend an extra time, extra effort just to give you clarity on the subject as a dentist, not as an orthodontist. For us, the only relevant position is postural respiration. There are some additional slides along with it which is hidden, which will help you understand the topic. They are taken from various sources. They are not relevant for ortho. If you don't want to understand this and you want to rest, you can rest. If you are confused and this is too much for you, don't read this. It's okay. If it is too much, you can relax. You don't need to know this. Because of these confusing terminologies, centric relation and centric occlusion terminologies are nowadays not used. They use RCP and ICP, which are more descriptive. So if you have rested enough, we'll move into our topic. Functional analysis. Why is functional analysis important for us? There are three functional analysis which is important for us. First is jaw functions. Second is functions of your orofacial, that is any dysfunction in your orofacial function, which is breathing, swallowing, or tongue thrust. And then there is an examination of TMJ. Because these three can affect your orthodontic treatment. Either they can get affected by orthodontic treatment or they can affect your orthodontic treatment. So we are going to study these functions. So there is three functions which are more important, not more important, they are important for us, which is speech, respiration and swallowing in terms of orthodontic treatment. But out of that also, the most important which is discussed most of the time is swallowing, tongue thrust. A lot of people pay a lot of attention to tongue thrust. We will discuss everything, then we will tell how is it important for us. Second is respiration. Third is TMJ. We will discuss all these in functional examination. So when you do your patient, you have to check for these things. Okay, we will also do chair side. So first coming on to this relationship between occlusion, that is what we discuss now. Functional shift, laterometry, lateroocclusion, deflection, deviation, COCR shift, all these terms which we use will all come in the relationship of occlusion. So how do we check relationship of occlusion? We have to just make sure first whether the patient has discrepancy between his maximum bite and his initial bite. So when the patient, remember we checked for pseudoplasty, what did we check? When the patient is biting, there is an initial contact and then there is a glide forward to maximum contact. So if there is a RCP to ICP discrepancy, or also loosely known as COCR discrepancy, or if you don't want to use this term, you can say that there is an occlusal discrepancy. If there is an occlusal discrepancy, it is normal to have 0.5 to 1 millimeter in most of the population, but if it is more than that, you have to find out the cause and attack the cause. So far clear? Now when we are discussing this, during this we also discussed there is a position where centric, the condyle is in centric, there is no contact in the tooth anywhere, but mandible is just opened at 2 or 3 millimeter from the occlusal position. That means this is full of pressure, then slowly mandible opens 2 or 3 millimeter, none of the tooth is touching, and all the muscles of your maxilla and mandible elevators, everything is in balance with the gravity. What do we call this position as? Postural rest position. So centric postural rest position is a position within centric relation where the muscles is balanced. Understood? So centric relation guided by condyle. Postural rest position, condyle is at CR, along with that muscles are at rest. So it's the special position in centric. Because centric is a range from 0 to 25. In between them there are multiple positions. So one of the position is postural, and as an orthodontist this is important for us. Now, why is it important for us? How is it important for us? How do we measure this? All this we will discuss now. Are you ready? Now that we have discussed the significance, we have discussed what we are measuring, you must be able to understand it better. Everybody knows what is this postural rest position now? Okay. So when we relax, we are seated in a relaxed position, patient is seated upright, and then we ask them to relax or we guide them to relax. The jaw slightly opens up from the occlusal position. And in this position, there is a gap between toes, isn't it? So there is interocclusal gap. This interocclusal gap is called freeway space. And it is often seen in canine region that freeway space is around 2 to 3 millimeters. Now, how is this relevant for us? As a clinician, I will make a connection to you first as a general dentist. How many of you have passed PDS? Yes, it's a serious question. Only 4? All of our quacks here? So everybody has passed PDS, isn't it? And then in previous curriculum, there is complete denture. So everybody has done at least one complete denture, isn't it? This question is because when I ask how many are giving complete denture, there is no raise of hand. So now I know that everybody has given a complete denture. Is there any tooth present in a complete denture case? Is there any tooth present in the patient's mouth when you are giving complete denture? No. That means you have to decide a position for complete denture independent of tooth. I am explaining prosthodontics, I am not explaining ortho. So how do you give complete denture? You first make the impressions, then you make the special trace, then you take the impression again, then you send to the lab or you make occlusal rim over it, and then you call the patient for the first time. When you call the patient for the first time, what do you call it for? Bite relationship or jaw relationship. This bite relationship, what is the first step? How do you start this bite relationship? You put the upper denture first or the lower denture first? Upper, because it's not a non-moving jaw. And what guides you for this? Fox plane. What is fox plane? Interpupillary line. And then you do what? You put the upper denture with occlusal rim and you start reducing it until when the patient is relaxed and you can see 2 or 3 millimeter of bite rim. That means aesthetics is your guide here. You are setting the height of the upper denture with respect to aesthetics. Function has not played any role. So far clear? Everybody can follow? After this, you put a lower occlusal rim and ask the patient to bite. You staple it together and you send to the lab directly. Is that what you do? No. What do you do then? You adjust the lower rim. How do you adjust it? Why do you adjust it? What is your guide there? Video VDR. Remember? What is this video VDR? You are giving your denture at a height which is not too high for the patient, otherwise they will get stressed and the denture wearing would be difficult and they will not wear the denture. Or if it is too low, then there will be overclosure and there will be drooping of the corners and then you have other problems along with that. The masticatory efficiency will be less. So you have to be within a range. What is that range? This is that range which we discussed now, freeway space. That means your denture should not exceed freeway space. Because muscle is at resting position in this space, so you have to keep your denture in between. And by now we know that in average population, when the patient is resting, there is a 2 to 3 millimeter space between the occlusal position and resting position. So once you determine the freeway space for the patient, that means once you determine the postural rest position, you deduct 2 to 3 millimeter because this is the average, and you will get a position where the patient's occlusion should be. And this is the guide, isn't it? This is how you make denture. Is clear? So what are we determining? We are first determining postural rest position. From postural rest position, we are marking 2 points and measuring it. This is vertical dimension at rest. And because studies tells us that vertical dimension as occlusion is usually 2 to 3 millimeter less than the vertical dimension at rest, you deduct 2 or 3 millimeter and you reduce your occlusal rims until you get that position, until the postural rest position you measured it was 50 millimeter and you keep reducing your occlusal rim until the patient bite and it comes to 48, 47. And then you mark this relation, you send for denture. Yes? Similarly in ortho, we have an appliance which is functional appliance and we do exactly opposite to it. We want our appliance to stress the muscles so that the muscles get activated. So we want to make the functional appliance larger than the VDR. Understood? So we measure the postural rest position. We see the postural rest position is 50. We should make sure the thickness of the mandibular block should be more than VDR so that we exceed this and activate the muscles. So the relevance is clear. How do we do it? We'll show you now. Everybody can understand why are we doing this? Why are we studying this? How is it important for orthodontists? Yes? Any questions? So now we are going to assess the postural rest position and its relationship with occlusion. So So first thing is, how do we bring the patient to postural rest position? There are multiple methods. You would have studied that. Either you ask them to say Mississippi, 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 or you ask them to lick their lip and then relax, or you guide them, you make the jaw relaxed and then leave it around. So there are multiple, or you ask them to swallow and then relax. So there are multiple methods. So one of these methods is command method, non-command method, guiding method. There are multiple methods. You can do a combination of two. So usually you bring the patient at rest by chin tapping. That means you hold the chin between thumb and your fingers, and you slightly ask them to relax, and you bite, move their jaw until it is relaxed. You would have seen some videos, remember? I showed you videos. And then you ask them to swallow or say Mississippi once. So we ask the patient to be in relax. And always it is done when the patient is sitting upright position, so that all the muscles are in tandem with gravity. So suddenly, after doing this, the patient will come into a position where the muscles are relaxed and jaw is slightly open. This position is what? What is this position? Postural rest position. At this point, you would have placed two marks at the nose and chin, and you will measure a dimension. This dimension will come to as vertical rest position. Yes? Then you will ask the patient to bite and then again measure the mark. That dimension will be VDO. So far clear? So what is the previous space in this patient? 3 millimeter. That we know that when the patient is in resting position, when the muscles are not activated, there is a gap of 3 millimeter in between the teeth. So if I want to make a denture, I want to remain in this limit so that I don't stress the muscles. But when I want to do as an orthodontist, I want to do a functional appliance, I want to activate the muscles. So I want to make the thickness of my appliance which is more than the previous space. So the thickness of a twin block or an activator would be 4 or 5 millimeter in this case. Do you understand? Everyone clear? Postural rest position, we want to activate the muscles, so we should go beyond the resting stage. We will discuss this once again when we will discuss. Please excuse, this video should be here and video should be here. When we discuss this later next time, it will be in functional appliance. We will go in details of this when we will discuss fabrication of functional appliances. So this part is clear. Remember that this is independent. Postural rest position is also independent of occlusion. It is a function of muscle. It is not affected by occlusion. There is no occlusal contact at this point. Centric relation independent of occlusion. Postural rest position is a special position when the condyle is centric and muscles are relaxed. It is clinically highly repeatable position because centric relation is a range. We cannot use a range to construct our devices. So we need a point in that range. And this is clinically highly repeatable. So it serves a better purpose for us to identify postural rest position and use it as a guide either to fabricate our functional appliance or our dentures or do full mouth rehabilitations. Because it's a clinically repeatable position, you can repeat it and get that position clinically. Is this point clear? So now that we studied postural rest position, one of our topic is clear. You understand what is a postural rest position? You understand why do we need to know postural rest position? Because we want to construct our appliances larger than postural rest position. Now another relationship between occlusion and rest is your initial contact to final contact, which we called it as RCP to ICP. Remember? Jaw is open 2 to 3 millimeters beyond the occlusion, it is postural rest. When it starts to close towards occlusion, it will touch one teeth first, that is RCP, and then it will finally close, guided by the occlusal implants, which is MIP or ICP. So the difference between initial tooth contact and final tooth contact and the maximum tooth contact, most of us will have 0.5 to 1 millimeter of difference. It is normal. But if it is more than that, we call it as discrepancy or deflection or functional shift. It can be anterior-posterior, it can be transverse. Is this point clear? And if this is more than 1 to 2 millimeter, it is relevant for us because it's a premature contact and then it can lead to pathological problems, which we have partly discussed as a functional shift or lateral occlusion in midlines. Now we will cover them again. So far clear? So in functional examination, we have first topic, which is relationship of occlusion. In relationship of occlusion, the first topic is postural rest position. Its significance is to construct functional appliance for us. Second topic is relationship of initial contact to final contact. This is relevant because it causes deflection and change in occlusion. So far clear? So I'll just, because this functional appliance topic is a big topic and slightly newer concept for you, I'll write it down here. So functional exam, we will send you all these pictures in the group later. In functional exam, the first one is occlusion relationship. In this one, there is number 1, postural rest position. BDR minus BDA. And its relevance is in functional appliances, isn't it? Second is RCP to ICP, also called as COCR, discrepancy. And its relevance is in occlusion discrepancy. Deflections or functional shift. Deflection, functional shift. So far clear? This is the clinical relevance for us. Here the clinical relevance is functional appliances. So now let us understand different malocclusion and their different functional shift which is commonly seen. I spend a lot of time in diagnosis and treatment planning because once we finish this course, if you're well versed with this, you can grow as a clinician. If we just discuss how to treat this case, how to treat that case, how to treat that case, you will have a set mold, and any case comes slightly different than that mold and you will be stuck and you will not be able to make decisions. So you spend one full module only on how to identify the problems and the potential solution will come throughout other modules. Yes? So usually what are the 3 patterns which you can see in a class 2 patient? Look here. Class 2 patient increased overjet. So you can either see a smooth closure of mandible, open, closing, coming to postural rest position, and complete closure to occlusion. So very smooth process. Then there can be one format where you close first and then the patient advances the jaw forward. Why does they advance? As a habit. Because the overjet is too much, they want to reduce the overjet, so they advance forward. Alright? Then there can be another biting pattern in between the two also. So let us see the different biting patterns now. So you are able to make this difference between, so this is at occlusion, this is initial closure to final closure easily. Number C is closing movement with mandible posterior sliding. So mandible goes up and then slides posteriorly. The reason we will discuss later. And there is another movement where the mandible closes and then slides forward. So there is anterior glide, there is posterior glide. Lateral glide we discussed in midline shifts, lateral occlusion. And then there is a smooth closure. So let us understand. So this is a class 2. If you see the class 2 has increased overjet, so patient habitually patient close smoothly from initial to final. Second is when there is an initial contact, patient can slide distally. When this condition happens, remember we discussed class 2 division 2. There is a retroclined incisor which pushes the mandible, cannot bite nicely, so they shifts backwards. So there is a posterior glide. Another case where patient has increased overjet. So patient wants to improve their facial features or they want to improve their biting efficiency. So they, as a habit, starts to bite anteriorly. So there is a habitual anterior positioning of mandible. Usually seen in class 2 division 1 because you have a lot of overjet, you have a scope of anterior positioning of mandible. Yes? see this example and how does it affect our treatment? It is very important. Please pay attention.
Bite normal. Very good. Bite, 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 bite. See, there is no gap here, okay?
So when you examine the case pre-treatment, this was the bite of the patient, and we decided to do all 4 extraction for the patient because she is a Bimax. Alright? During the treatment, we again checked, and during checking we realized that patient has a habitual anterior positioning. Okay.
Relax, don't push this. Relax, 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 relax. Okay, slowly bite, slowly bite, slowly bite. Okay. See the gap between this? So the patient has dual bite tendency. On assist bite, she is biting in centric relation at the back, open. Bite normal in the front, and this is her usual habitual bite. So a very difficult diagnosis.
So usually functional examination is not discussed in a lot of teaching, learning mechanics. But when you see this, here the overjet is normal. Here the overjet is 6 to 7 millimeter. Does it change your treatment plan? Absolutely. So what can be the consequences? Let's say, if I would have been careless and not examined this nicely. So initial examination, overjet is normal, patient has proclined upper and lower teeth. I should do all 4 extraction. I do all 4 extraction, do my treatment, close all the spaces. During the course of 2 years, patient is changing his bites because occlusion is changing constantly. So the previous habit of patient positioning the jaw forward is now gone. Now they are finding their new engram of muscle and new occlusal biting position with the new dentition which you have created. And suddenly they are guided by CR now and they start to bite back. And after your treatment is finished, patient ends up with 6 millimeter of overjet. Because you retracted the lower and you retracted the upper, and there was an initial overjet of 7 millimeter and you retracted both, and this 7 millimeter overjet is still maintained. So if you miss out the diagnosis, the treatment plan will be upper 4 and lower 4 extraction. And if you are able to diagnose correctly that this patient habitual bite is this, then your extraction pattern will be upper 4 extraction only, so that you can close the overjet. So this mistake has been done many times with many experienced clinicians also, because if they can't find a problem, they don't look for a problem. Understood? So this happens in a busy practice. This happens when you don't have a set protocols of examination. So if you don't see any features of dual bite, you just don't examine for the dual bite. But we set a protocol. We set a checklist whether patient will have or not. We will check for these things. And when do we check? In which cases we check? We'll give you the protocol for that, so that you will not miss out on this. So if you see, there is a huge difference in overjet. Here it looks like a bimaxillary protrusion, class 1 molar, class 1 canine, endon molar, endon canine, procline upper and lower, and the treatment plan would be upper and lower 4 extraction. But before we send the patient for extraction, we were checking for dual bite tendency, and we could confirm that she has dual bite. So we changed our treatment plan to a upper 4 extraction only. Similarly, in class 3, we have already discussed a pseudo class 3 and a true class 3. So you have a position where the class 3 is biting uniformly. Then you have a position where there is an initial contact and the mandible shifts forward. That is a pseudo class 3. So you know the difference between
class 3 and the patient bite, they will touch the anterior teeth somewhere or any prematurity, and then the mandible will slide forward. And for a normal class 3, skeletal class 3, it would be a normal smooth closing of the mandible in the anterior position. So now we are going to check, and I'm going to push the mandible back to see whether the patient is habitually biting anteriorly or not. Open please. Close. Open. Close. So if you see, this is a smooth curve, smooth closure of the mandible. Open. Relax, relax, relax. Bite. So still, if you see, the negative overjet is still maintained. Open. Relax. Bite. I am applying a lot of pressure backwards, but it will not happen.
So what we have done is we have discussed all these things in different sporadic topics. Anterior glide we discussed in class 3 cases. Posterior glide we discussed in class 2 division 2 cases. Then lateral glide we discussed in midline when we were discussing midline lateral occlusion versus lateral. Now we are combining all three in functional examination. Understand? So this is not something new which I am teaching you. It is just a old thing in a new topic consolidated so that it is easy for you to remember and examine in your patient. Alright? So now by this time, midlines I will not repeat again. You know what is the lateral occlusion, what is laterognathy, what is the difference between the two. Yes, we have discussed it multiple period of time. So now that we know that we have to do functional examination, we have to check for dual bites. Which patient should we check this? Should we check it in class 2 or should we check it in class 3? Both. What about class 1? Should check. Which type of patient should we check for functional glides? Class 3? Class 1 also? He said class 3 and class 2. She said class 1 and class 3. She said class 3. That means every patient? Yes. We should check functional examination in every patient. Why? Because in class 3, usually there is anterior glide. In class 2 division 2, there is usually posterior glide. In class 2 division 1, there is a dual bite, anterior positioning of the mandible. In cross bites, there is lateral shift. So in all the cases, you will have all the different slides. In class 1, you may have a lateral slide because of a blocked out tooth or because of a posterior cross bite, convenient shift of bite. In class 2 division 2, you have a retrocline incisor pushing the mandible backward, posterior glide. In class 3, you have a pseudo class 3 anterior glide, and in class 2 division 1, there is an increase overjet. You have a habitual anterior positioning of the jaws. That means almost all the malocclusions are covered. And where scenario you may have overlapping. So you may have anterior glide along with this lateral shift. So examination, functional examination is necessary in all the patients. Now when should we examine it? When should we examine it? At what stage? Because I did examine, but then I realized that I missed out something. So when is the right time? Should we examine it in the beginning? Should we examine it in between the treatment, or should we examine it during the end of the treatment? Because bite is constantly changing, right? Every time you move the tooth, the bite is changing, so bite can change. So when do you think is the right time? Very good. So you must examine it in the beginning to rule out if there is any reflection glide, habitual glide, dual glide, everything. Then you should do it before, that is after leveling and alignment. Because the deflection can be caused because of, don't write it's in your note please. It's in your notes, pay attention. You are not here to take notes, you are not dental secretaries, you are dental clinicians, you are here to understand what is written. Okay? At the beginning, when you are diagnosing, if you diagnose is the best. But the habitual engram of the patient is so strong over 20 years they have been biting in a certain position that sometimes you keep guiding them, they'll keep biting in the same position until this engram is broken after the tooth movement. So once you start your treatment, leveling and alignment will happen, occlusal discrepancies will correct, the tooth will align themselves, prematurities will either go off or they will become more or they will be new premature. So that occlusal engram is changing in their brain and this muscle memory is changing. So after leveling and alignment, the bite can change for a patient. So first is at the beginning, second is after leveling and alignment. These two positions you must check for any changes in the bite. So sometime at the beginning you may not find it, but after leveling and alignment, once the prematurities are gone, teeth are aligned, the occlusal pattern is changed, they may unmask any habitual biting habits. That is after leveling and alignment. Then just to be very safe, if you are planning any extraction or any irreversible process, to correct overjet, then double check before sending out for extraction. Then maybe if you would have missed, then you must double confirm there is no functional shift like in the patient which I just showed you. If I would have missed at that stage, I would have done all four extraction and then ended up in trouble. So far clear? And after that, just before debonding, you must also check, because sometimes when you give long class 2 elastic for long period of time to match the occlusion, instead of tooth moving forward because of the occlusion force, patient starts to position the mandible forward. So when the patient comes to you, every time you check occlusion is corrected to class 1, I will debond, and after that the patient stops wearing elastic and the mandible goes backwards. So if you are giving out class 2 elastics for long time, it is good before debonding, you must check for 1 month, ask the patient not to wear elastic anymore and check for functional examination whether the patient is positioning the mandible forward or the dentition has aligned itself with class 1. So far clear? So we covered the discrepancy in anterior posterior dimension, the different bites, also in lateral dimensions, the lateral occlusion. Any confusion in functional examination in occlusal relationship and postural rest position? Anyone? No. Now TMJ, I need not teach you TMJ. This is your job. You can read about it. Different examination method of TMJ. Only relationship with orthodontics and TMJ I will tell you. TMJ is a sleeping lion. In orthodontics there is saying, don't kick the sleeping lions. That means if the patient has TMJ issues, don't touch that patient at your level. Send them out to resolve the TMJ issues first. The recent researches have proven orthodontic treatment neither increase the TMJ problems nor reduce the TMJ problems. So if the patient comes to you that somebody has told my problem is because of my teeth, you do the orthodontic treatment to correct my TMJ, you tell the patient recent research doesn't confirm that orthodontic treatment can cause or relieve TMJ issues. I will do your orthodontic treatment for all together different region, but TMJ may or may not correct or may even increase, so it is better to address the TMJ first and then do that. So the idea is, don't promise, don't do anything related to TMJ as an orthodontist at your stage. There is a separate branch in orthodontics where oral medicine, oral radiology, oral surgeon and orthodontists, they do complex treatment over a period of time involving the splines, rehabilitation of those to relieve TMJ with occlusion. But this is beyond our scope. So even for me, if the patient's chief complaint is TMJ, I tell them to go and handle the TMJ first. The TMJ specialist will find the orthodontist who is in their team and they will work together. I will not do it. Understood? So for TMJ, you can examine, you know how does the examination, intraoral palpation of the muscle, extraoral TMJ examination, trapezius plate and all. So as an orthodontist, if a patient comes to you, they have minor clicks, minor crepitus, but no pain, no problem, no limitation of mouth opening, no shifts here and there, you can take up that case. The clicks can be physiological also. But if click crepitus is associated with tenderness, pain, limited mouth opening or severe deflections, then it's a TMJ first case and you should refer for TMJ problems. Clear? Everybody clear about this? So what are the analysis? You can do TMJ examination by either palpation of the TMJ joint extraorally, palpation of the muscle extraorally, intraorally, auscultation and click and crepitus, and also CBCT for TMJ view and dynamic test MRI for TMJ function. We can do all those things, but we are not doing it as an orthodontist. Now coming on to the last topic of functional examination or ENT, which is the functional examination of orofacial functions or orofacial dysfunctions. So in this we will cover any dysfunction of respiration, its effects on malocclusion, any dysfunction of swallowing and its effects on malocclusion, and any dysfunction in speeches. Okay? I'll give you a 5 minute break. You can relax and we'll start after 5 or 10 minutes. If there is any question or you need to ask in relevance to functional shift, you can ask.
be a normal smooth closing of the mandible in the anterior position. So now we are going to check to see whether the patient is habitually biting anteriorly or not. Open please. Close. So for a pseudoplasty, when the patient bite, they will touch the anterior teeth somewhere or any prematurity, and then the mandible will slide forward. And for a normal class 3, skeletal class 3, it would be a normal smooth closing of the mandible in the anterior position. So now we are going to check. And for a pseudoclastic and the patient bites, they will touch the anterior teeth somewhere or any prematurity, and then the mandible will slide forward. And for a normal class 3, skeletal class 3, it would be
again, I keep repeating the same thing. Don't try to memorize, don't try to recall, don't try to remember, and don't try to establish all the link. This is just the day 2. Okay? You are not equipped to do that. You are not expected to do that. Only you are expected to understand what we are trying to explain you. At that moment, if you understand and you forget it after 15 seconds, it's okay. We are just clarifying your doubt, building your concepts now. They are sporadic dots here and there. Later, the linkage of these dots and the flow of the thoughts will happen in subsequent modules. The course is designed that way. It's not a feel-good course. I have not designed a course to make you feel good that you are learning so many things and never be able to apply later on. It is designed in a way when as you grow older in this course, the confidence will keep building and your thought process will becoming more smoother, and then you can grow on your own without my need. Okay? So the first module, it is okay to feel a bit apprehensive. It is okay to feel a bit confused. When you go back, you read up, the clarification will come in, you will understand more, and in subsequent modules, you will apply these clinically, you will concretize the concepts. Okay? There will be some random sentences which I will say, and you will not understand it now maybe. And when you will ask the question, I will answer them in short for now, but later on when the topic will come, you will understand, the aha moment will come later. Understood? So, again, please don't feel overwhelmed, and if you're feeling overwhelmed, it's perfectly normal. It is too much information in a very small amount of time. So now, once we discuss all the other things, we come on to orofacial dysfunction. In this orofacial dysfunction, actually nothing much of relevance is there, but we will still cover it one time so that you have a confidence that you understand the things. Okay? So we will discuss the literature, the clinical significance, and after that we'll forget it. Alright. So we see a lot of, in the PDAs, they will discuss a lot of mouth breathing, this breathing, that breathing, refer to ANT, do and all. So okay, I will tell you, if your patient has mouth breathing, what will you do? Tell them you have mouth breathing, and after that, you don't do anything about it. Seriously, as a clinical practitioner, out of 100 clinical practitioners, 2 will maybe do something about it, who are obsessed with sleep medicine and industry. But 98% of us, we accept the problem. Okay? So now, coming on to respiration, the idea is somebody is a mouth breather. There can be multiple reasons about it. It can be habitual. It can be because of some blockages in the nasal passage. As an orthodontist, you cannot do much about it. You have to refer them to ENT to solve this problem, first and foremost. Now the second thing is, if there is a problem which cannot be solved or the patient doesn't want to go for any surgery for ENT, you have to inform the patient you have a mouth breathing problem. This problem is leading to a certain malocclusion, if it is leading to a malocclusion in that patient. So if your patient has well-aligned occlusion, everything is good and he's a mouth breather, we don't care about it. But if your patient has constricted arches because of mouth breathing, we care about it. And what do we tell the patient? This is the problem. You have to go to the ENT, solve the mouth breathing. After that, come to me, I solve your occlusion. They say, I don't want to go for any surgery, I don't have mouth breathing, this and that. Make a note out of it, refer the patient to ENT. After that, they don't want to do it, they counter sign. Then I will do your orthodontic treatment. It is prone for high relapse. Understood? Clear? That means if there is any breathing problem which you identify, refer them to ENT for the clearance or any additional procedure which is needed. If they do it, very good. If they don't do it, take a counter sign, maintain a record, inform the patient, I will treat you. There is chances that if you don't wear retainer, because of your breathing habit, the chances of relapse will be slightly higher than other people. Clear? Can we proceed now? So, we all know that there is mouth breathing, there is oral breathing, and there is combination. Most of us are combination breathing pattern. That means mostly we breathe through our nose. Sometimes when we are stressing hard, we breathe through our mouth. Okay? But there are some people who are obligate mouth breathers. That means they cannot breathe through their nose. There can be multiple reasons about it. We are not the people who can deal with that problem. We have to refer them to ENT. Alright? But how can we detect whether the patient is a obligate mouth breather or it's a nasal mouth breather or it's a combination? So nasal and combination is okay. Okay? But if the patient is a primary mouth breather, when you put a two-way mirror, the same mirror which we use for your photography, it has two side mirrors, right? When you put in the patient's lip area, and if it's a mouth breather, the fogging will primarily happen in the lower portion. If it's a nose breather, the fogging will happen most primarily in the nasal area. That is the top region of the mirror. This is one of the tests. But obviously, when you're testing, patient's breathing pattern changes. So it's not an absolute method. Secondly, they make mustaches for the patient. They keep cotton like this, and when the cotton is flapping downward more, it's a nasal breather. When the cotton is flapping upward more, it's a mouth breather. All these methods are actually not the right methods. I mean, as soon as you make the patient conscious, the breathing pattern changes. When you're stressed out, your breathing pattern changes, isn't it? It is subconscious. Similarly, when you put certain things in your mouth, when you put the mirror, patient will close the mouth and then breathe. So even if he's a mouth breather, he will breathe through nose for that particular period of time. So you have to do sleep studies, sonography, all those things to really identify whether the patient is mouth breather or not. So these were outdated long back, 50 years, 100 years back, they were testing like this. But the idea for an orthodontist is, if you see any dental features related to mouth breathing, then the mouth breathing becomes significant for you. Otherwise, if the patient has mouth breathing and it's not any occlusal problem, it's not leading to any problem malocclusion, then it's not a concern for you. So don't go on looking for mouth breathing in every patient. If you see any features, droopy face, sleepy face, long face, inflamed gingiva, constricted maxillary arch, proclined teeth, it is a sign that patient may be a mouth breather, and then you can check for these. Understood? If your patient has well aligned arches, good occlusion, good looking patient, there is no problem. Even if he's sleeping with the mouth wide open throughout his life, it is not a problem for you, isn't it? So you will have typical features for mouth breathers. If you look for the features, you can send the patient for examination. You can do preliminary examination to detect mouth breathing. If you suspect mouth breathing, you can send the patient for ENT to check mouth breathing. There is a lot of controversy which is happening in orthodontic specialty regarding sleep medicine, extraction causing mouth breathing, giving out medical expander for every patient because there is a sleep mouth. So there is a separate small subspecialty being generated, being marketed by companies who sell out their product and making every patient a mouth breather. Understood? It is not like this. Science has not proven. Orthodontic extraction has never caused mouth breathing. So far, there is no research supporting it. So if somebody says that, a lot of non-extraction forum who are proponents of non-extraction marketing, they will say extraction causes mouth breathing. It is not. There are certain appliances like myobraces. They will detect mouth breathing in a 7-year-old and give myobraces. So Please don't do that. There are certain groups which are giving parental expander in a 6-year-old, 7-year-old, 10-year-old, 20-year-old, 50-year-old, telling that this patient has a mouth bleeding, so we should expand the arches. Understood? So don't get sold out for these gimmicks. The idea is if you have dental features and you have clinical features which is correlating mouth breathing to the dental malocclusion, in that case you need to intervene, otherwise don't bother much. It is not your field, sleep medicine is not your field. Okay? Coming on to swallow. Now again swallowing, previously they were having open bite, spacing and all, they couldn't blame anything, so they started blaming tongue for everything. Tongue is the strongest muscle, so tongue must be the cause of it. Recent studies have proven that, before even starting the topic I am telling you, so if you want to sleep after that you can sleep. Recent studies have proven that 80 to 90% of the cases, tongue is not the problem. The problem exists and then the tongue adapts to it. That means there is a chicken and egg solution conundrum. Whether the chicken came first or the egg came first. Understood? So, till now we were having all this questioning. Later the scientists proved that it's the egg came first, isn't it? Or the chicken came first. Still we don't know. But in mathematics we know that. The research has proven that tongue is not the culprit in 90% of the cases. This tongue thrust, all these things, they were concepts of previous ENT. Nowadays we know that in 90% of the cases, tongue thrust is adaptive. That means if you have an open bite, and because when you swallow, if you don't close this open bite, the water is going to come out. So as a habit, when a child is small, they starts to put tongue in that area close to maintain the mouth sealed. And over a period of time when they are developing, this becomes as an adaptive tongue thrust. Primary tongue thrust is when a tongue thrust is causing the malocclusion. Secondary or an adaptive tongue thrust is when there is a malocclusion and his tongue is about positioning itself in those extra spaces. So most of your cases which you will see would be an adaptive or a secondary tongue thrust, not a primary cause for the malocclusion. Understood? This concept established, then we will discuss everything else. Is there any doubt, anyone? So what is a normal tongue thrust? What is a transient tongue thrust? How is it relevant? We will discuss now. The next 10 minutes we will discuss tongue thrust. So normal tongue thrust, normal swallowing, how does it develop? When a child is small, when the child is born, they are not eating, they are being breastfed. So breastfeeding, it requires a totally different mechanism of swallowing as compared to swallowing the solid foods. Alright? So what do? They position their mouth around the breast and the tongue forms a trough or a curvature and the milk dribbles down onto the back of the mouth. Patient's face muscles and elevator muscles are not well developed. So we don't call it sucking, it is called suckling. That means patient is not creating a negative pressure. Milk is being exerted by the mammary muscles and the child is just allowing, creating an atmosphere where the milk can dribble back to the throat. So during this process, the child is not actually swallowing, not actually creating a negative pressure, but because the mandible has to move for the milk to dribble back and the mandibular muscles are not mature enough to stabilize the mandible, they have this thrusting or bobbing action and the facial muscle helps to stabilize this action. So when you see a small child taking a bottle and trying to drink milk, you will see a lot of facial expressions. So because mandibular muscles are not mature, facial muscles take over to stabilize these functions. Okay, so that is the child swallowing the milk. As they start growing teeth, slowly their swallowing pattern, eating pattern and biting pattern starts to change. So there is a phase where the occlusion is developing and they are moving from a liquid diet to a solid diet. So you have a transient malocclusion, transient swallowing pattern. That means it could be a mix of normal mature swallow like you swallow now and a combination along with that of a child swallow. So child swallow is mouth open, child not closing the mouth and swallowing. They're not removing their mouth every time against the nipple and then swallowing that will be back. They're not doing that, right? They're in the same position, mouth is open and they're swallowing. Yes? And how do you swallow? Close your mouth, swallow, then open again, then eat, then close the mouth and swallow. So there is a phase of transition. So far clear? And as we grow old, we have all complement of teeth. We wean away from liquid primary diet to a primary solid diet, and then our swallowing pattern change from a child swallow to or infantile swallow to a mature swallow, where our facial muscles no more required to support our mandible. Our mandible muscles are mature enough, and the mandibular elevator muscles help us close the mandible while we are swallowing, and there is no facial expression. We don't see people swallowing like this, isn't it anymore? So, this is how our swallowing pattern develops. Now, if there is any problem or there is any habit which is developed during this process, you have aberrant swallow, which is called as tongue thrust. That means at any point of time, either patient has some problem or he develops some abnormal habit, they change it to a tongue thrust or aberrant swallow. So tongue thrusting is just an adaptive mechanism of some underlying problem. That some underlying problem can be the child has been long-term fed by bottle and they have not adapted to the solid diet for a very long time, so now they have developed the habit. Or for some reason, patient has an open bite and they have developed the habit of positioning a tongue between them, so it is adaptive tongue thrust. So there can be multiple reasons, but the idea is tongue thrust is a sequelae of any aberration during this maturation process. Now if you see, I have put another topic, detailed infantile swallow. That means it is not transitional, it is not an adult mixed with infantile. It is primarily infantile swallow pattern seen in adults. It is very, very rarely seen, you will never see it in your life. Mostly it is seen in people who have neurological disorders where the swallow doesn't develop at all. And you would have seen in some movies, some comedy movies or something, you would have seen patients jerking their mouth around when they're swallowing eating. So you will see these in neurological ward, you will see these patients, but usually you will not see. These are the patients who are retaining the infantile swallow pattern. That means they are actively thrusting the tongue here and there and causing the malocclusion. So these are the patients where the tongue is the primary cause for the malocclusion, but there is a neurological problem. But in most of your cases, tongue is an adaptive. That means if you solve the malocclusion, your tongue thrust should come down. Okay? Now, after having all these discussions and understanding, how is it clinically relevant for us? So I'll just give you 1 minute to relax, to understand what is important for us. Meanwhile, if you have any question between infantile, transition and mature swallow, you can ask me. You understood how from a child to a mature swallow we have developed a swallowing pattern, isn't it? So in a normal swallow, we have teeth in occlusion, lips are closed, mandible muscles are activated, and facial muscles are not activated. This is a mature swallow. So you don't see facial grimacing, you don't see facial features activated when the person is swallowing in a mature swallow. Whereas in a small child, because they are constantly being fed by a bottle, the mouth is opened while they are swallowing. They need to stabilize their mandible by facial muscles. You see facial changing. Teeth are not joining together, they are teeth apart. And transition phase, in between the two, you have a combination of two. So it is normal to have a tongue thrust in a developing occlusion. It is a normal feature. Don't go on giving tongue clip and all in a 5-year-old or 6-year-old patient, because it's a normal feature. But if this persists in a permanent dentition and it's causing a malocclusion, then you may need to intervene. Now, can we go to the next topic, clinical significance of this? So, we have discussed all this, swallow, what is a transition swallow. Please go through this slide once to differentiate between infantile and a mature swallow. After that, we will go in for the clinical. Please go through this slide. Understand what are the features, only then you can differentiate them. Infantile swallow, also known as visceral swallow because it is not under the control, also known as jaw apart swallow, and it is usually associated with tongue thrust. It's a normal feature. It's a normal feature in a child or mixed with normal swallow, mature swallow, and infantile swallow is a normal feature in a transitional developing occlusion. Whereas in an adult, this may be a pathologic feature. Whereas a mature swallow, which is usually seen when all your permanent teeth is erupted and the occlusion is developed and you are on a totally solid diet, in that case, you will have teeth together swallow. Teeth will be closed momentarily when you swallow. There will be no mouth open when you swallow, lips will be closed. Your muscles of mastication will be activated to close your mouth when you're swallowing, and facial muscles have no role in swallowing. So far clear? As we discussed, most of the tongue thrusting can be because of, as a habit, because the patient was bottle fed for a very long period of time and they have developed the habit, or mostly it's an adaptive behavior. Adaptive behavior, patient has a space malocclusion, and because of that they position their tongue to close off those spaces while swallowing, or they have an open bite. So it's an adaptive rather than the primary cause of the malocclusion. Previously they thought all the spacing, all the open bite is caused by tongue thrust. Now our understanding is you have a malocclusion and the tongue position itself in that empty spaces. So if you close that malocclusion, the tongue thrust will improve. Tongue thrust can be classified as simple, complex, or retail infantile. There are multiple classifications like for occlusion, but the most relevant one we are discussing. So if you have a simple tongue thrust, it means that the open bite or the tongue is thrusting between the canine to canine region. Usually this is a simple tongue thrust. Prognosis is good because it's mostly adaptive. If it's a complex tongue thrust, that means the open bite exists from premolar to premolar. The prognosis is slightly more difficult. It's not a dental, it's a skeletal open bite. So dental open bite restricted to canine mostly. Skeletal open bite, entire jaw is open wide, so you have open bite from premolar to premolar. So tongue thrust previously they classified as tongue thrust because they were thinking all these problems were because of thrust. Now retrospectively we know that the tongue is just being adapted. So the prognosis of an open bite where the open bite is from premolar to premolar is more difficult. A prognosis is moderate or fair in a complex tongue thrust or a skeletal open bite, and a simple tongue thrust which is associated with the dental open bite is restricted to canine. The prognosis is fair. Now clinical significance. If you have case where open bite is restricted to canine, it is within your scope to take up the case. If your open bite is extending beyond canine, it makes the case very difficult to handle at your stage. Probably refer it. Now don't ask me, sir, if my open bite exists just to the first premolar, can I take it? Yes, if you think you can take it, it's not extending, it's not, the facial features are not matching with the skeletal open bite, you can take it. What are the facial features? Long face along with open bite, skeletal open bite. Normal face along with canine to canine open bite, dental open bite. Dental open bite you can treat easily, skeletal open bite will be difficult at your stage. But we will discuss both. We will discuss the treatment of both so that later on when you are more mature, you will be able to handle those cases also. But in the beginning, restrict yourself to dental open bite. Clear? Now, how do we differentiate whether the patient is a simple tongue thrust or a complex tongue thrust? See, all these examinations are pointless. Nonetheless, we are going to explain you so that you understand how to do it and then you can reject it, rather than rejecting it outright. So, we know the feature of a simple tongue thrust. Teeth is together or teeth is apart? Apart or together? Simple tongue thrust. Teeth together swallow. Mandibular muscles are activated to close the jaw. Simple tongue thrust. Complex tongue thrust. Teeth apart, swallow. That means mandibular muscles are not activated to close the jaw. Yes? Clear? So how do we differentiate between the two? If you measure the activity of muscles, if the muscles of mastication are activated, most likely it is simple tongue thrust. If muscles of activation is not activated, most likely it's a complex tongue thrust. How do you measure that? You try. So you keep your hand in the temporalis muscle, ask the patient to take some water, ask them to swallow. When they are swallowing, if you can feel the activity of temporalis, that means while swallowing they are closing their mandible. That means prognosis is good because it's a simple tongue thrust. When we are swallowing, you can't find any activity of the temporalis. That means, and they are making the faces. That means the muscles of activation. Don't write. They are. I will tell you what. Don't write. Don't take notes because it's not very good. So when you swallow and you can't find the activity of the muscles, that means most likely it's a complex tongue thrust because muscles of mastication are not activated. Now, is this relevant? This is not relevant. Once you start observing the patient, they change their swallowing. Alright? They used to first ask the patient to swallow, then part their lips and see. You try. Drink some water. Take a sip of water. Keep your lips open like that and try to swallow. Swallow. Try that. Until you try, you will never know. Take the little water, otherwise it will come out. Try to hold your lower lip and swallow. So, are you swallowing normal? It is difficult. Your swallowing pattern changes. So, normally if you have to really observe the swallowing pattern of the patient, you can't do all these things because you change the swallowing pattern of the patient once you start observing or putting mouth mirror or any observation or pulling the lip apart. Yeah. Tasha was fine in the water flow. So, first learning is when you're checking this, don't keep your face very close to the patient. Jokes apart, we don't do all these things nowadays because research has already proven. Okay, now we will discuss this examination again later, but I just want to show you the recent research from the most respected orthodontic textbook, which is the textbook Profit. Alright? So if you don't believe me, no, believe this. Now, to cause any malocclusion, there has to be at least 4 to 5 hours of constant pressure on a tooth in a day at least to start moving that tooth, isn't it? That means if the pressure is less than, this is the threshold, that means less than 4 to 5 hours, if there is no pressure on the tooth, it is less than 4 to 5 hours, the mediators of tooth movement doesn't get activated and tooth doesn't move. That's the reason if you keep doing like this for some period of time, your tooth doesn't start moving. You have to do it constantly for a long period of time, every single day, for more than 5 to 6 hours, then you can have tooth movement initiation. So the threshold is 4 to 5 hours per day, every single day. Now if tongue thrust is the problem, is the cause for making your tooth move out and all those things, that means tongue has to push the teeth every day at least for 4 to 5 hours, isn't it? Now when you swallow, there is a momentarily thrusting of tongue, that is when you check, right? Patient is not sitting and doing like this. So the tongue thrust is observed when the patient is swallowing and we see the tongue is being thrust. That means tongue thrust happens when the patient swallows. So how many times do you swallow in a day? Maybe 1,000 times, maybe 1,500 times. And every swallow, if it is 1 second, that means 1,500, 1,000, 1,200 or 15 seconds you swallow. This is much less than 4 hours or 5 hours of threshold time. That means your teeth cannot be moved with tongue anymore. But tongue can cause this malocclusion. When can it cause this malocclusion? You would have seen patients with coming with, as a young, they didn't have any spacing, they did not have any coordination, but when they grow old, their teeth became like this. Why did it happen? As we grow old, our periodontium becomes weak. And normal tongue activity can examination of tongue thrust and all is usually now very irrelevant. Tongue positioning can be a cause. If the patient is for some reason keeping his tongue passively, always adapted to the teeth and pushing it, it can cause the problem. That rarely happens. If you would have seen this in patient with autism, you would have seen this in patient with Down syndrome, then they have tongue resting position which is bad. Yes, but in normal patient you will see. So, in short, tongue thrust is adaptive, is not the primary cause of the malocclusion. We have understood over a period of time. Now, do we give tongue clip or not? So, if you see an open bite patient, do you give tongue clip or not? What do you see in Facebook and Instagram and other? Do they give tongue clip? Yes. So, should we give tongue clip? In the current light of evidence? Should we or should we not? See, now the purpose of tongue clip is changed. Previously they were giving tongue clip to thinking that the tongue is causing the malocclusion. We still give the tongue clip, but not because of the same reason, but because if the patient have an adaptive tongue thrust, he has over a period of developed the habit, and when you are correcting this malocclusion, this habit can slow down your correction or can interfere in this correction and make the treatment longer. So to correct this habit which has been developed over a period of time and also to aid and reduce this interference during the treatment, we still do give the tongue clip. But just to change the habit. We know that the tongue is not the primary cause, but if it's a severe tongue thrust and patient will keep thrusting his tongue, if you need to take 6 months to close the open bite, you will take 12 months. So if you give tongue clip, you will be able to close it in 6 to 6. So it's just to reduce the time, increase the efficiency, and correct the patients over a period of time, this habit which is developed. To correct that, we still do tongue clip. Understood? So the relevance of tongue thrust is reduced, but the relevance of tongue clip is still maintained. Understood? Everyone? So this would be the end of our functional examination, E&D. If there is any doubt, you can ask me before I show you one of the case. So this is one of my case. If you see, it's a severe open bite, spaced out dentition. I have given a tongue clip. If you see, there was a severe malocclusion. The tongue clip has its own function. We will discuss this. All these things we will discuss. But I want to tell you, we are not giving tongue clip because the tongue is the primary cause. We are giving tongue clip to aid our treatment so that we can do it more efficiently. So to reduce the interference, to aid for the inclusion, and to increase the efficiency of our treatment, we are giving the tongue clip. But if the tongue clip is broken at this point, my tongue clip was broken at this point. So the open bite was, let's say, 4 millimeter, and it was corrected by 1 or 2 millimeter, but still there is a subsequent open bite, and the tongue clip was broken. I did not replace it because it is too much of a small space in which the tongue can actually enter and interfere. So I know that tongue is not the primary cause, and now the space is not so big where the tongue can come in and interfere in my treatment. I did not replace it, and I could easily get the correction. That means if you don't give tongue clip also, you will be able to do a case, but it will be more difficult for you to do it. Understood? So, is there any confusion? Yes. Yes, do get up now. Yes. Yes. You understood. So the clinical relevance is, if it is very mild open bite, 1 millimeter, 2 millimeter, you don't want to give. If you give, it is okay. The reason would be different. But if you don't want to give, it is still okay not to give a tongue clip. But if it is more than 2, 3, 4 millimeter, your tongue can keep interfering in your treatment. So it would be a good idea to give a tongue clip. Clear? See, as a clinician, we have to see cost to benefit ratio also. If you give a tongue clip, there is additional 3 appointment which is involved. First, you will take the bands, take the impression, then you will send this to lab. Then when the patient comes in, you will try. If it is not fitting, you will send again to correct it. Then again call the patient. Then bond the conflict. Then it is broken in between. Then again do all this. So if it is not worth all this procedure, why to trouble yourself and the patient with all this? So the idea is you have to make this decision as a clinician. If it is 1 to 2 millimeter, it's not worth it to go through all this. It is okay. But if you think it's a difficult case or you don't want to take the chances, you can go ahead and give it even 1 millimeter of open bite. But we will discuss all these things as we progress. You will see in which cases it is okay to give, which is not okay. But for now, in open bite, because it's a difficult malocclusion to deal with, every open bite, treat it like a difficult open bite. Understood? Module 2, you will get a good idea about how to deal with open bite and deep bite situations. Speech is something again controversial. Orthodontics can help the speech or may not help the speech. We are not the right person to really diagnose and comment on it. Our role is secondary. There are speech therapists, their role is primary. So if the patient comes to you that somebody told me my speech problem is because of what? My tooth is not aligned well, can you correct that? Either I can correct your teeth, whether your speech will be corrected or not, I cannot guarantee. So as of now, there is certain malocclusion, certain tooth position which are linked to certain speech problems. If the tooth is the problem, the speech will be corrected. In case where the tooth is not the problem, the speech will not be corrected and you cannot guarantee it to the patient. So if when a patient comes to me as a chief complaint of speech problem, I make them aware that I can correct their admission, speech may or may not correct. If you still want to do the treatment, I will do it for you. But if you think that you should correct the speech with orthodontic treatment, otherwise I don't want the treatment, I cannot guarantee it. Understood? So let us revise what have we studied so far which is clinically relevant for us. Take a break for 5 minutes only, then we will revise this for 5 or 10 minutes and after that we can break for lunch. Take 5 minutes break so that you can, now from this point onward you can forget everything what we studied since yesterday. Only if you remember this is good enough. Only if you remember this slide, it would be good enough for you. See, over a period of time, what I have noticed is if you schedule theory and clinical from the very beginning, you tend to get confused, you tend to understand at that point but never make those clinical linkages because all the theoretical knowledge comes in parts. So the theoretical knowledge you get in first module, you would have forgotten and not make a linkage until you reach to module 5. So what we have done is, we have given you all the necessary important theoretical knowledge in module 1 so that over a period of time you keep repeating the important ones and you can make those linkages. Alright, so if you feel module 1 is slightly heavy for you, don't get stressed. The theory part will keep coming down with every module and the clinical part will keep going. Can we start with the revision? Keep your phones, keep your notes, no need to make any notes. Just pay attention here, 5 or 10 minutes. These are the features you will examine your patient chair side and they are relevant for your clinical practice. Okay, if you are doing anything, just stop for this moment, 10 minutes, focus. So as the patient comes to you, you will check some extraoral features first. Most important would be a profile of the patient, isn't it? First, the patient will come to you, you will check the patient's smile from the front. So it would be an incisal display. Why is it important? If the patient is a deep bite patient, you need to know to correct the deep bite, should I include upper or should I include the lower, or should I include both? So if the patient has increased incisor display, you can include the upper mode. If the patient has a reduced incisor display at smile and also they have deep bite, then the target of action for us would be mostly lower arch. Because if you include upper mode, they will have no incisor display, they will look old. This point clear for everyone? Similarly for open bite, if your open bite cases and the patient incisor display at smile is more, they have gummy smile, then to correct the open bite, you cannot extrude the anteriors too much. Otherwise, you will increase the gumminess. In that case, you will have to target posterior inclusion. So the incisor display at rest is a very important landmark for you to decide where you would want to position your incisor during your treatment. Normal incisor display at rest is 1 to 2 mm of incisor edge display. Upper incisors are shown when the patient is at rest. It's a range. If the patient is showing 3 mm, still okay. 0 mm, it is still okay. At rest, not at smile. Similarly, when the patient is smiling, incisor display of 80% to full incisor display is considered normal. For younger patient, 1 mm or 2 mm of gingival display is considered normal. For girls, adult girls, 1 or 2 mm of incisor display is not normal, but it is aesthetic. They look younger, so it is desirable. That means, all in all, we can consider that 1 mm of incisor gingival display along with full incisor show at full smile is desirable and acceptable. More than 2 or 3 mm of gingival display is not desirable, it looks gummy. So far clear? These values will be there in your notes further, but we are just revising whatever we studied so far. So first thing which you show is incisor display at rest and incisor display at smile. You have to check this in your patient. So these two things we have checked. Now the third would be profile and skeletal problem. You check whether the profile is convex, concave or straight, and you do this, put the finger on the patient's face and check whether it's moving up or down, to check whether the maxilla is prognathic or mandible is retrognathing or both, or it's a class 2 or a class 3. So this you need to diagnose chair side. Any confusion here? Then you need to know the growth pattern of the patient. As we discussed, the growth pattern is very closely related with your treatment planning, because horizontal growth pattern has a stronger bone, stronger anchorage value, and also the mucogingival pattern. In horizontal growth pattern, the thick gingival biotype is more common, whereas in vertical growth pattern, thin gingival biotype usually exists, so you can't do more of non-extraction expansion. So all these decisions, we will make those decisions over a period of time, but relevance I am telling you, so we need to know growth pattern. Along with growth pattern, we need to know growth status, whether the patient is growing or non-growing, so that we can check whether the patient is a good candidate for myofunctional appliance, or orthodontic appliance, or orthognathic surgery. So far clear? Ricketts E-line. E-line, as I told you, we wrote here that page is being turned, but E-line is nothing but a relationship of nose, lip and chin with respect to the teeth. Yes? We will establish all those facts when we are doing hands-on here later. We will establish that. Okay? Nasolabial angle. Nasolabial angle will decide whether your teeth are too proclined and you need to retrocline them, or you need to maintain the incisor position so that your nasolabial angle is not changing. There is a confusion about nasolabial angle. We will discuss that also later on. Okay? Lip length, lip type and lip consistency. So if it's a thick fleshy lip, it will not fall back with the tooth movement as much as a thin lip will fall back. There is a clinical significance. So if you have a normal looking face that is an average face and you are confused whether I should do extraction and retraction or not, if it's a thick fleshy lip and you do extraction and retraction, profile will not change too much because the lip will not fall as much. Whereas if it's a thin lip, it is more sensitive to tooth movement. So you have to base your decision based on that. As we we see the cases, as we discuss the cases over a period of time, these things will get more clear. Okay? Facial asymmetry, dental midline, lateral occlusion, functional occlusion, all these things you understand. So these are the things we will check in extraoral features. For intraoral, you check for any missing, decayed, or impacted tooth, whether there is a retained deciduous tooth or not. Then you check for overget, overbite. Then you check for molar relationship, canine relationship. After that, you will check for midlines, whether it's a dental midline shift or a skeletal midline shift, whether upper is shifted or lower is shifted or both are shifted. You check for periodontal support and gingival support. Check for crowding and spacing. And accordingly, you will base your treatment. If you are able to make decisions based on all these factors, probably you will make a good decision whether you require extraction or you don't require extraction. So this is the basic controversy or most dilemma we have as an orthodontist, right? Otherwise, it's nothing. You want the bracket, put the wire, and it's learning alignment, but the decision making is basically clear. Whether you require extraction or you don't require extraction. If you don't require extraction, how would you manage a case? And if you require extraction, how would you manage a case? And all these factors will help you make these decisions. Alright, we will take a break at this point. I will still be here for 5-10 minutes. If you have any question related to any of these features, you can ask me. Later when you come in, we'll have a short lecture on your cephalometrics introduction so that we can do hands-on chair side demo and cephalometrics. Okay, so we'll have two demos, two hands-on today. Chair side and cephalometrics. Any questions you can post on Slido. There was a question of why do we target overcorrection of 1.5 or 0 mm for SPE. We already answered that question because SPE have high chances of relapse. So we want to make it flat so that we will end up in somewhere 1 to 1.5 range. If there is a question, you can ask. If there is no question, you can go for lunch. It is around 1:15. We will assemble back at 2 o'clock.
过 website 有，哪一个比较好？也是一样。你是讲用手画？用手画。用 website。website。因为用手画麻烦，然后很多variables是每个人画不一样。是 OK。你等一下 OK 好。